These days, osteoarthritis is by far the most common. So when I look at the surgical procedures we do, it's probably over 90%. And that's just plain old-fashioned wear and tear on the joints. Oftentimes, a person will have a family history. So when I talk to people, the person will say, well, my mom, my aunt, my father, my grandfather, when I shake the family tree, there's typically a history of some arthritis within the family. The other kind of arthritis is post-traumatic, and that is more and more common. Significant knee injuries and significant hip injuries will lead to wear over time simply because the cartilage doesn't repair itself well. Broken bones heal well, but the cartilage itself does not repair itself. It forms scar tissue, but it doesn't form back to normal cartilage. And the scar cartilage doesn't have the normal resistance to the wear and tear that normal cartilage has. One of the interesting things, and I tease my rheumatology colleagues, is the rheumatologists do so well with the DMARDs now that the rheumatoid arthritis patient is rarer and rarer and rarer as a surgical patient. When I started in orthopedics more than a couple of years ago, the rheumatology docs were relatively limited with their medications. They used a lot of steroids, and steroids didn't work that well and had a lot of side effects. But the DMARDs, the disease-modifying agents for rheumatoid arthritis, are actually pretty good now, so we see less and less. Gout and pseudogout typically are managed medically and rarely require any surgery. And avascular necrosis is something that is not uncommon, related to injuries, related to the use of steroids, and sometimes related to the use of alcohol. So for us, the osteoarthritis and the post-traumatic arthritis forms the large majority of the patients who we take care of surgically. And this is a patient who has pseudogout. You can see this space here is normally wide open, and the calcification within that space is the calcium of the pseudogout. And this is more typical for avascular necrosis, this bottom diagnosis, where the joint space here is good, but that area of the bone has died and collapsed as a result of steroid medication. This is something that we all know. Arthritis leads to pain, stiffness, and weakness. The weakness is often because the pain interferes with doing normal activities. If you can't run up and down the stairs, if you can't do your gardening, if you can't do the work around the house, around the yard like you're used to doing, the muscles aren't getting exercised, and the weakness is often secondary to the pain. The stiffness is a result directly of the arthritis. And the issue that we'll keep talking about is the limitation of activities of daily living. When we're talking about the decision to have surgery, it's the person who's giving up too many of their activities every day. It's one thing to change from one kind of exercise to another because it's more comfortable, but if you get to the point that you can't exercise, you can't take care of the house, you can't enjoy your children and your grandchildren, you can't enjoy hobbies, when you start losing the activities of daily living, that's when we need to get a little bit more serious about some of the activity. As I alluded to, lifestyle modifications for activities of daily living is often important. I'll have people come to me who are runners, or people who come to me who are stonemasons, or have jobs or other activities that are really intensely physical. And one of the discussions for them isn't, should I have an operation? One of the discussions for them is that balance of change in their activities. Is there an exercise that they can choose that's a better exercise for them, one that they can do comfortably? I have to be a little careful with the diet and weight loss kind of discussions. I'm the pot calling the kettle black. I do try to exercise, but I don't exercise enough, and I do enjoy a good meal. So I admit to being part of the problem here. But exercise, even without weight loss, exercise by itself has real advantages for the joints in terms of muscle health and bone health and joint health. So a good exercise program doesn't have to be intense exercise, but something that you do repetitive, something that you do for 25 or 30 minutes, something that makes you a little short of breath or a little tired at the end of the exercise session is a very appropriate aerobic activity, especially if it doesn't aggravate your joints. Water exercise for us is sort of the classic go-to exercise. The advantage of being in the water is all the pressure's off the hip and the knees. And oftentimes people who can't exercise well on land will find that water exercise program makes a big difference for them in terms of activity. And we'll talk a little bit more in a minute about the anti-inflammatories and the injections. So as I alluded to, swimming is really, truly important. And the other thing that's interesting is, and important, is shoes. One of the things that we see not uncommonly is the modern synthetic shoes, the surfaces don't look worn out when the materials have lost their resilience. And so the impact of walking on bad shoes on hard surfaces can be a really important question. People who run for fitness understand that, but those of us who are more sort of amateur fitness buffs are not as aware of surfaces and shoes. The other thing I struggle with is canes. Who here would happily use a cane? Happily? Or because you kind of have to? One of the really interesting things is a cane in the opposite hand from a sore side can make a huge difference in activity. I bore my residents with the physics, so if anyone really wants to go through the vector diagrams, I invite you to stick around afterwards and I'll set it all up for you and show you the arithmetic. The take-home message is that a cane in the opposite hand is hugely effective of taking pressure off a sore joint. And it is the thing that oftentimes people, if they can really change their activity level simply by using a cane. I also tell people who are sore, leave the cane in the car. Because if you're going to go someplace and run a lot of errands, grab the cane, use it to get around and do the errands. Will it make the joint last longer? No. Will you be more comfortable doing basic activities? Absolutely. So the low impact aerobics are really absolutely the key. The muscles are stronger, the joints are healthier, your heart's healthier, your weight's down. Exercise is really a very important component of it. It's not a no pain, no gain setting. There are some situations where we will tell our patients no pain, no gain. But arthritis pain with a certain exercise tells you, think through again whether or not this is an appropriate exercise program for you. And here's how you do weight control. It's one of the problems I sort of have discussions with patients because it's very difficult. Let's talk a little bit more about medications. The basic medications that are the safe medications or the effective medications are the over-the-counter anti-inflammatory drugs. NSAID is non-steroidal anti-inflammatory drugs. We're all familiar with Advil, Motrin, Aleve. Those drugs are sold over the counter not because they're ineffective, but because of the safety. When the FDA makes a decision about a drug to be sold over the counter, it's a safety decision, not an efficacy decision. So Motrin and naproxen are really the go-to medications in terms of the anti-inflammatories. Now, they don't work for everybody. And people have difficulty with the traditional anti-inflammatories. The COX-2 drugs can be very, very useful. For plain old-fashioned osteoarthritis, for the person who's not having inflammation, Tylenol is a really good arthritis drug. And one of the things that I will often mention to people is that nowadays Tylenol shows up in so many different medications. Do read the labels so that you don't end up getting Tylenol from too many different directions. But Tylenol in all the different forms can be very effective for people with osteoarthritis who don't have a lot of inflammation. The NSAIDs become important if you have inflammatory components, and we can talk about that a little bit more. We truly try to avoid narcotics for people with chronic diseases. Narcotics in people with chronic diseases is somewhat of a slippery slope. And occasionally I'll use narcotic for the person who's not sleeping well at nighttime, but I really dislike using narcotics during the day. There are a variety of other medicines out there over the counter, things like glucosamine, MSM. There's a long list of different things. Most of those nutraceuticals, most of those natural products don't have solid proof of their efficacy. But if you feel better with them and you stop them and you feel worse and then you restart them and you feel better, they're working. So there's nothing about any of the meds that I've talked about with osteoarthritis that will change how the joint's going to be in the long run. We've been talking really about symptom management. We don't have a way to truly make the arthritis better over time, except for, as I said earlier, with rheumatoid arthritis, the DMARDs, the disease-modifying agents, can really, truly change the course of rheumatoid arthritis. And that's been a big change over the last decade. Injections. We rarely inject the hip, but injections around the knee can be hugely useful. And the two groups of medications we use are the anti-inflammatory drugs, the corticosteroids. We don't use steroids anymore by mouth for osteoarthritis because the thing that's happened over the last 10 or 15 years is to use the steroids topically, put the drug where you need it to work. Put a small amount there instead of using pounds of it by pill. Put milligrams where it needs to work, whether it's a rub-on cream for a rash or whether it's an inhaler for asthma or injections for arthritis. Do the injection of the anti-inflammatory medication where it's going to do its job. That way you can avoid the side effects of the steroids. The other thing is viscosupplementation. It's actually a pretty good name. What happens in joints that wear and tear, one of the side effects is not only does the cartilage break down, but the lubricating fluid breaks down. The quality of the fluid, because we feel this all the time in the OR, the quality of the fluid loses its viscosity. And you know from oil, oil has that nice sort of slimy, viscous feel. It's a good lubricant. But the water-based lubricant that's naturally inside the joint, the materials, the molecules can break down and they lose their viscosity. The viscosupplements are great for mechanical symptoms, for the person who finds that their inflammation is controlled and their pain is relatively well controlled, but they find that the farther they go in the morning or in the afternoon, the more the pain they have, the viscosupplements can work very, very well for them. The viscosupplements are just approved for the knee. So at the present, that's one of the very specific indications for the viscosupplementation. It used to be you had to have 3 or 4 shots over a month, but some of the newer agents you can use single injections. So instead of me jabbing the needle in the knee every week for a month, and people get tired of that, I put the needle in once and they get the whole dose and they're off and going. The viscosupplement average duration is about 8 months. I've had people go a year, year and a half after a dose of viscosupplementation, but they're approved for repetition as often as twice a year if need be. So here's the meat of the talk. What's the reason to have surgery? And we've talked about these things a little bit, but let me put them together. Pain that interferes with activities of daily living every day significantly, forcing you to change your life significantly, that we can't get better with medical management. Those two requirements are really important in our discussions. And I can tell you, somebody outside asked the question, well, will the pieces wear out? They will. The younger the person, the more careful I am with medical management. If I have somebody who's truly a senior, who's got horrible x-rays and they're having pain, I'm not going to put them through as much medicine because the senior is not likely to wear out their artificial joint. If they're to the point that their activities are so intolerable, the senior is more likely to get the medication. But I can tell you if a 40-year-old is having trouble with activities, I'm going to work very, very aggressively to try to keep the 40-year-old out of the operating room. The youngest hip replacement is actually the one that I did on Tuesday, is 15. So there are indications for younger individuals. The younger the individual is, the more incapacitated they need to be before we're going to talk seriously about surgery. But young individuals can have surgery. My oldest is 102, so you guys are all going to have to wait a few years if you want to try to break that record. I don't know if that's a Guinness Book record or anything, but that's the range. Obviously, the most common age group is in the 60s and the 70s is really the most common age group for osteoarthritis. So let's talk a little bit now about the surgical end of it and what we do. The end result of all the arthritis that we talked about earlier is the bone-to-bone contact. The cartilage is got no nerve endings, so the cartilage, as long as it's separating the bone surfaces, you don't get pain. Once there's an area of bone-to-bone contact that you're walking on, the pain starts to become a real problem. So this person's had the hip replacement on one side and is getting ready to have the hip replacement done on the opposite side. So when we've decided that I have pain that interferes with enough activity every day and I'm not getting better, then I go back and look at the x-rays and make sure that what the person has is something that's going to be fixable with a surgical procedure. Or have I missed a different diagnosis and we didn't need to go off in a different direction? So it's this sort of bone-to-bone contact that typically makes the decision. So far we've talked about the should I a little bit. And so the next discussion is what bearing, what fixation. So what are the risks? Can we make the risks less by going through some of the surgical procedures? And so let's talk a little bit about what the kind of implant is. And I brought some examples. For both hip and knee replacement, there are surgical risks, and I'm going to talk a little bit more about these. The surgical risks are the other reason that I'm always careful to make sure that the decision is important. The conversation between me and the patient needs to be confident that we're making the right decision because there are risks. And at the present, in general, the medical risks are blood clots and infections. Those are the two things that we spend a lot of time thinking about, working on different medications, always trying to gain that extra little bit of advantage in terms of cutting down the risk of blood clots and infections. We feel pretty good about it, but we're still not completely happy about those two things. Dislocation has to do with how the implant's assembled, how it's put together, and it's one of those things that, to a certain extent, is surgical skill. Occasionally, I'll have a patient who has really bad luck, before especially the hip or the knee is completely healed. But to a certain extent, dislocation risk is related to implant selection and how the surgeon puts it in. But as we talked about, and we'll talk more about now, the long-term issue, especially for the younger individual, is will the bearings wear out and will the fixation of the implant fail over time? And so I'm going to talk a little bit more about those now. When John Charnley designed hip replacements, he started in 1959, 1960 in England. Really the father of joint replacements for us. And the two things that he did was to pick plastic as the bearing to walk on, and to use bone cement, which is actually a first cousin of superglue. It's a doughy superglue instead of the liquidy superglue we're used to. Those were the two things that Charnley put together in 1960 that led to the modern evolution of joint replacement. But one of the things that's happened is that those two things are now replaced in a lot of situations because the plastic doesn't hold up and the cement doesn't hold up as well as we would want them to. One of the first things that changed was cement. If you look at cemented hip replacements, the quotation that I would talk to when I was talking to patients about risk 15 years ago was about 1% per year failure rate, which meant at 15 years there was a 15% failure rate, at 20 years there was a 20% failure rate of the cement. So I would talk to a 50-year-old individual, expect to live to 80, and there's a 1 out of 3 chance that the cement was going to fail and a 1 out of 3 chance that that person was going to require more surgery down the road. We orthopedic surgeons stole cementless technology from the dental surgeons. The implants for dental work is really where a lot of the basic science research was done in the 80s. So the cementless technology that we use now has grown out of the dental work that was done. So the cementless implants are marvelous because once the bone attaches, the bone is healthy, the bone is solid, the bone is part of you, the body will take care of that implant, the interface will not break down. So the cementless technology at the present is the most commonly used technology in the hip because of its supreme durability. Now, early on, one of the problems was until we figured out how to use it well, and still now, occasionally a cementless implant will not heal correctly with the first surgical procedure. Now, it's one thing to tell a person 20 years that they've worn it out. People understand stuff wearing out. But if I tell you at 6 months it didn't heal right, that's not such a happy conversation. But we're now so predictable with our cementless designs that I don't remember cementing a hip in. It's been a long, long, long while. So although, especially early on, there was a small early failure rate, the technology at the present is so predictable that in the hip, it's largely replaced cement. The bearing materials are important because the inflammatory effect on the bone. When we talk about bearings wearing out, all of us would think it's like the tires of my car wear out. The tread goes away, it's worn out, it needs to be replaced. But what happens is the bone around the joint implant actually is broken down by some of the debris. And the debris is related to the immune response of the particles. So one of the goals is to pick particles that have less reaction and materials that have fewer particles. So at the present, for the young active individual, although the ceramic is still relatively new, because it has the lowest wear rate, that for me, for the young individual, that 15-year-old I was talking about, got ceramic bearings. They got cementless implants and a ceramic bearing. But because we only have 15 years of experience, and because there is a small risk of breakage, for the person who's not at risk of wearing their plastic out, the metal on plastic with 50 years of experience going back to Charnley in 1959, 1960, is still the gold standard for us in terms of hip and knee replacements. The plastics have gotten better. The plastic engineers, the chemists have done cross-linking and figured out sterilization and machining methods, so the plastics have gotten better and better and better. So at the present, it's a horse race between ceramic on ceramic and the plastic bearings. Metal on metal recently has gotten a black eye because although the wear rate was relatively low, there's been question over the last year, year and a half, especially about some of the metal toxicity of a metal on metal bearing. So we've largely backed away from metal on metal implants around the hip. Incision. We do have to cut you. And one of the reasons I bring the implants is people will often say to me, well, I want a little tiny incision. Well, if you look at my implants, you know, little tiny incisions don't really work. Now, I can make a little incision and stretch the skin, but I've got to take some stuff apart to get those things into people. So minimally invasive surgery is something that people talk about. It's used heavily as a marketing tool, but anyone would agree that if they're going to have one of those things put in their body, it's not a minimally invasive operation. So I have a little bit of difficulty with minimally invasive. If you have your gallbladder removed through a couple of small incisions, that's minimally invasive. If you have your anterior cruciate, a little ligament pulled in through an arthroscope, that's minimally invasive. But if you have one of those things stuffed into your hip or your knee, I don't buy it. Seems intuitive, but one of the things that we've seen is that with some of the studies with small incision surgery is that there's been a slightly higher complication rate, more dislocations and more problems over time. I'm not going to say that as a blanket statement because there are superb surgeons out there who can do a very good job through a very small incision. But minimally invasive surgery oftentimes is kind of a bait and switch thing in terms of how we market joint replacement. And so at the present, it's predominantly an empty promise. So when people say to me, how big's my hip incision going to be, what I say is to put one hand here put the other hand here and then lift them up, that's what you're getting. So if your thigh is this wide, I got to climb in. Okay? If your thigh is this big, I can do it through a smaller incision because I can get there without having to have such a big incision. So the size of your thigh is really probably the best predictor of how big your incision or how small your incision is going to be. So here's the preferences at the present for our group for the hip replacement. We really prefer cementless fixation. We really prefer plastics as the standard of care for most of our hip patients. There's a subset of people where ceramic bearings become important, and this is part of a discussion I'll have with an individual. Age is not useful, it turns out. If I have a 75-year-old who plays 18 holes 5 days a week, and on Sunday they play 36 holes, that person's going to get a ceramic bearing. Okay? I have a 50-year-old who's had a heart transplant and needs a kidney transplant. They're probably going to get a plastic bearing because that person doesn't need the risk of a breakage or something like that, because they're not going to get the benefit of a ceramic that will really truly last. And I used a relatively traditional incision. So let's finish up with the knees. This is a fairly classic osteoarthritis x-ray. The surface on the back of the kneecap is worn out, and the surface on the inside knuckle is worn out. You've seen people with that sort of bow-legged look. This is why you get the bow-legged look, because this surface wears down, but this surface doesn't. So when this wears down, the tibia, the lower leg, kind of comes around in this direction. About 10% of people will get a valgus or a knock-knee deformity. It's just because their wear pattern's a little bit different. 90% of people get that particular look. We want to fix that alignment because it turns out if you leave the alignment poorly aligned, you'll end up with uneven wear on the plastic. So my patients love it when the knee looks right. You know, they think, oh, he did a good job. Well, for me, it's more important than just having it look right. I want the tissue to be balanced. I want the plastics to be balanced. I want the knee to work well as an artificial knee. So the alignment to us is really quite important. Same thing. This is what I said for the hips, and this is what I'm going to say again for the knees. Pain that doesn't respond to non-operative care that interferes with activities every day. Exact same question. So if you all go home and somebody says, what did Eric Hume talk about? If you can say pain with activities of daily living unresponsive to non-operative care, I will have done my job. That's really the key take home. Now there are other things with the knee that we can do. How does arthroscopy fit in? Are there osteotomies? Is there a realignment operation? What's a partial replacement? Is MIS? Should my knee be cemented? Are there partial knees? And let's talk about those things a little bit more. There's more choices around the knee, and I'll kind of go through those quickly. Arthroscopy, unfortunately, doesn't cure arthritis. There's actually a fairly big study done about 7-8 years ago in Dallas that really says for most people with osteoarthritis, it's a sham operation, that most people over the age of about 50, 55 won't really benefit that much from an arthroscopy. Now that's a blanket statement that you have to be careful about, because the person who comes in with very clear mechanical symptoms from a meniscus tear or something that's fixable with an arthroscope, we have to be a little bit careful. But typically when I start with a 55 or 60-year-old individual, typically arthroscopy is near the bottom of my list, not the top of my list. In and out the same day, and it may help certain mechanical symptoms. So the well-picked patient will benefit from arthroscopy, but in general, in arthritis, it's not a useful operation. Knee replacement is the gold standard. And this shows a cemented knee. This fuzzy white stuff here is the bone cement. And you can see a little bone cement on the back of the kneecap and some bone cement that's holding the piece on the thigh bone. And the artificial knee is more of a resurfacing. It's more like putting a tire on the wheel of a car, whereas a hip replacement is replacing the wheel and the tire completely. We shave off just enough bone and cartilage to fix the alignment and allow this new healthy surface to be put on. And when we make the cuts, I want to make sure that this is really perpendicular to the axis here, and that the overall alignment of the leg is the 3 to 4 degrees off perfectly straight. That is really the natural alignment that we all have. So this is our workhorse. When we compare other operations in osteoarthritis, this is the operation that's the gold standard that we compare to. And so for the vast majority of people with osteoarthritis, this is really the right operation for the person who needs to have an operation. Now, the partial knee replacement works well if the other part of the joint's really good shape. Okay? If you look at this knee, that's very healthy. The preoperative x-ray, the alignment of the knee here was really, really good. But when you looked at the x-ray, there was that one knuckle was worn out. So we can leave the kneecap alone, we can leave that outside knuckle alone, and we can just replace this one surface. The knee has three surfaces. We call this a unicondylar or uni knee replacement. Subset of people, maybe 1 out of 100 of the patients I see are appropriate patients for a uni. The problem with a uni is that if you then develop arthritis in the kneecap or in the other knuckle in the next 7 to 8 years, you're back getting the uni removed and getting an artificial knee put in, whereas if you had the full knee to begin with, that might have lasted 25 or 30 years. So the discussion in terms of making the decision about who gets a uni, we really need to be careful that we're picking the right operation. And I talk a lot about, well, how do you do on steps? How do you really feel on that outside knuckle of the knee? We really spend some time trying to understand if there are symptoms there in the other surfaces of the joint. So the discussion with your doc to determine whether or not you're a good candidate is really, truly important. So the difference between, oh, I don't have the pre-op, is when this surface is this irregular, this person needs the full replacement. When that other surface looks this good, oops, didn't go far enough. That surface looks that good because it's new and replaced. For a younger individual where they've got arthritis mainly on that inside knuckle and they're badly bowed, if you cut the bone and straighten the lower leg out, you can take the pressure off the more worn side without actually replacing the surface. We like the osteotomies for the 40-year-old because they're very, very durable, but they don't give the great pain relief of replacing the surface. So our preferences with artificial knees, the total knee is the gold standard. Cement works better in the knees than the cementless designs, although there is interest in developing cementless designs. And much the same thing that I said about minimally invasive surgery. You have to be a little bit careful about that. If the doc is really superbly good in a small incision surgical procedure, then there's some value with that. But in reality, it's overstated. It's not got the value that we would like it to have. Arthroscopy, the partials, the unis, and the realignment osteotomies can be useful and would be part of the discussion if you were appropriate candidate for those things. So let's finish up with safety. This, to me, is where we really, really spend our efforts. I've mentioned to several of you that the slow evolution of designs is appropriate evolution, but we're always looking for the angle for safety. How can we cut infection risk? How can we cut blood infections? How can we cut infections in the joint? Very, very interested in this. And we have several partners. Our main scientific organization, the American Academy of Orthopedic Surgeons and the Association of Hip and Knee Surgeons, are really where a lot of our clearinghouse scientific activity is done. This is where we have discussions. What have you learned? What have I learned? You know, what's good? What, you know, where do we need to come up with improvement? The federal government used to be called Medicare. It's now CMS. Has also been a leader in terms of helping organize safety projects. SCIP is Surgical Care Improvement Program. And those are all areas where we get information and share information about things that we can do. And the real focus, it's not the only things we work on, but the real focus is our infection and on blood clots. And I'll talk mainly about those. The websites are obvious websites, and they're useful to browse. There's lots of information for patients as well as for docs in any of these websites. Surgical site infections account for something like 1 out of 6 of the infections that occur in hospitals. We really need to get this under control. You know, what are the things that we can do with this? And they're a way too common complication of surgery. The key to surgical site infections has to do somewhat with having systems set up to make sure that the right things are done. Things such as hand washing, sterilization, a lot of those things are just a standard part of what we do. But one of the things that we really, really have to focus on is to make sure that we get the right drug into the patient in that hour before surgery so the drug levels are appropriate at the time that we do the surgical procedure. So a lot of the systems we have set up are intended to double check and triple check that these things are occurring. Same thing with blood clots. The blood clots occur in 1/4 of patients if we're not able to prevent them. And something like 1 out of 12, 1 out of 13 of the patients will have a pulmonary embolism. When the blood clot moves to the heart and lungs, that's a real problem. Blood clots in the legs are a hassle, but blood clots that move to the heart and lungs can kill. So this for us is the other big issue. And this is from the old days before prophylaxis. So the same thing with, with the antibiotics. We have to start and be aggressive, and we have to have double and triple checks to make sure that the meds and the treatment and the prevention occur at the right time. DVT prophylaxis needs to go considerably longer than does the prophylaxis for infections. The American College of Chest Physicians, about every 3 years, gets together and reviews all the data and makes recommendations. And so this is one of the things that we follow very carefully. And the recommendations are not just for joint replacement, but it's across the board in terms of DVT, venous stasis, and pulmonary embolism. So with elective hip and knee replacement, we want to do one from column A and one from column B. We want to have a chemical prophylaxis, either a heparin, I typically use Lovenox, Coumadin, and a mechanical. Turns out the best mechanical prevention for blood clots is to just throw you out of bed. You know, the person who's up and walking around, that's probably one of the most effective things we do. We've learned that we used to literally kill people with kindness by letting them sit in bed. So if the patient's in bed when I come in the afternoon to make rounds and they've not gotten up, I get that finger up and I go, we need to get you out of bed. And they hurt. They don't want to get up. I understand the pain. I understand the aggravation of getting up. But I also know that we can literally kill people with kindness. But in addition, we can put stockings and boots and compression boots on people. The compression boots do much of the same thing that the muscle activity does when we get people up. It compresses and relaxes the veins and helps make sure the blood is flowing through the legs. This is why on long airplane trips, make sure you have your bottle of water, and make sure you get up and walk up and down the aisles. Unless you're flying near New York or Washington, I would stay in my seat at that point. But the activity in the legs is very, very effective in terms of lowering the risk of blood clots. Back to the surgical care performance. Not only do we know that we need to do these, we need to grade ourselves and keep track of how we're doing so that if we find we're not doing something as effectively as we think, we can go back and do that. So here are some of the measures we use. These two first measures are just, are we doing the right things? Do we give the drugs and do we give them at the right time? And then the bottom two are, do people come back in the hospital with blood clots? Do people have pulmonary embolism? So part of the measures are to make sure that we're doing the right thing up front, but then part of the measures are to see, do we have an adverse effect later on to help us understand what can we do, what went wrong, what can we do better. So these things are something that, you know, we're partnering with organizations across the country with this. So the safety is a commitment by the doctors, by the nurses, by the hospital, by the patients. Part of our preoperative education process is to have you understand how important the wipes are to cut down the bacteria on the skin, how important getting your preoperative clearance, understanding the risk for blood clots. Do I have a cardiac history? So we all need to work together constantly on all of these things. And the coordination among the doctors, the staffs, our patients in the hospital is really important part of the coordination.